Hello ladies and gentlemen, my name is Margaret Clark. I'm the Director of Home Therapies for Fresenius Medical Care South Asia Pacific, and I'm going to talk about peritonitis and the ISPD guidelines. So specifically we're talking about some of the complications, the management, and just at the end I'll talk about a few strategies to prevent peritonitis. So peritonitis is inflammation of the peritoneum, which is usually caused by bacteria, and it's one of the most major complications of PD. It accounts for 24% of technique failure. Now the ISPD guidelines recommend no more than 0.5 episodes per year, so that's our benchmark, our goal that we need to achieve. So what are the complications of peritonitis? So the cytokines remain elevated for 42 days following an episode of peritonitis. It can lead to ultrafiltration failure. It causes adhesions and scarring of the membrane. During peritonitis, the patient has increased protein loss because the membrane can become quite leaky. The risk of hospitalisation is increased, so increased 33% of hospitalisation, which increased costs, and of course catheter loss and transfer to hemodialysis. And 16% of patients die as a result of peritonitis. So the symptoms from the latest guidelines from ISPD: a cloudy bag and or abdominal pain and or fever, nausea, vomiting and diarrhea. So immediate treatment is mandatory. Even if symptoms are mild, you still need to treat them straight away. So asepsis and sampling is critical. So blood culture bottles are the preferred technique for bacterial culture of the PD effluent. As well as that, we can send a bag of fluid away for gram stain, culture sensitivity, white cell count with differential as soon as possible before the initiation of antibiotics. So it's ideal that the dwell is 2 hours, so the fluid has been in the patient 2 hours before you take the sample, and that or longer than 2 hours, so a minimum of 2 hours. The samples must reach the lab within 6 hours, and if you're taking a sample from the bag, you need at least 50 mils. So if they've got a lot of pain, you can do 1 or 2 quick exchanges to relieve pain. If you're getting a high number of culture negative, you need to review the culture techniques in the lab. So for the diagnosis of peritonitis, according to the ISPD guidelines, the clinical features must be consistent with peritonitis, so that's your abdominal pain, cloudy effluent, but they need to have white blood cells greater than 100 units per litre with 50% polymorphonuclear neutrophils. So the white cell count differential is more important than the absolute count. We need to get a gram stain, and that's very fast and is positive in up to 40% of episodes, predictive in 85% of cases. And then after 24 to 48 hours, we follow up with the bacterial growth, and 85% of samples should yield an organism. So we need to initiate antibiotic therapy immediately once you have your gram stain back, and it's important to follow that as well. So first generation cephalosporin or vancomycin in the long dwell together with an aminoglycoside, or third generation cephalosporin. So the antibiotics are given intraperitoneally, and this will cover both your gram positive and gram negative organisms. So you need to allow 4 to 6 hours dwell for the initial IP antibiotics. So this means that anyone on APD should be changed to CAPD to allow for this 4-hour dwell. The guidelines recommend prophylactic antifungal agents, and particularly if they're going to be on antibiotics for a long period of time, and heparin may be administered if fibrin is present. So if the peritonitis is severe, the patient may need to be hospitalised. They will require pain relief. You need to observe the fluid balance because they can become volume overloaded very quickly, and you need to monitor your blood sugars and observe even for dehydration if they're vomiting and diarrhea. Remember that they have increased protein loss, and the duration of the antibiotic therapy should be 14 to 21 days, depending on the organism and clinical response, and the fungal infection is treated for 4 weeks. So the laboratory needs to be followed up after 24 to 48 hours. You need to check that the effluent is clearing, and particularly if there's no improvement after 48 hours, you need to repeat the cell counts and cultures and monitor the white cell count in the effluent. So the final therapy is based on culture and sensitivity. So whether it's gram-positive or single gram-negative or multiple gram-negative, which often implicates a bowel organism. Culture negative shouldn't be more than 15%, or if it's an anaerobic bacteria, which can indicate perforation or fungal organisms. Now, if there can be a differential diagnosis if the effluent is cloudy, so a culture positive infectious peritonitis with sterile cultures, so we can have chemical peritonitis. Calcium can be caused by calcium channel blockers, eosinophilia of the effluent, hemoperitoneum, malignancy, and so on, off the specimens taken from a dry abdomen. So the antibiotic treatment is, the preferred route is intraperitoneal unless the patient is septic. So the combination of glycopeptides, which is vancomycin or teicoplanin plus ceftazidime, is considered to be superior to other regimes. So for gram-positive coverage, first generation cephalosporin with the glycopeptide-based regimes. Be aware of MRSA, and you need to keep your levels greater than 15 micrograms per mil. For gram-negative organisms, aminoglycosides such as gentamicin can be administered daily as intermittent dosing, and there are other antibiotics. Avoid prolonged courses of aminoglycosides, which means usage greater than 3 weeks, as this can cause vestibular and ototoxicity. Now, when you're administering the antibiotics, they should be administered using an aseptic technique. So you can place the iodine swab or chlorhexidine swab over the injection port for 5 minutes prior to insertion of the needle through the port. And then it's best if you let the antibiotics dwell for 6 hours to allow for adequate absorption. And check the drug compatibility if you're mixing 2 drugs together. Use separate syringes for adding the antibiotics. So just some terminology that you need to be familiar with. A recurrent peritonitis is a peritonitis that occurs within 4 weeks of the last peritonitis or the the antibiotics stopping, but it's a different organism. A relapsing peritonitis is within 4 weeks of when the last dose of antibiotic was stopped, and it's the same organism, or it could be a sterile peritonitis. A repeat peritonitis is when the peritonitis has occurred more than 4 weeks after the last dose of the antibiotic, and it's the same organism. Refractory peritonitis is the failure of the effluent to clear after 5 days of the appropriate antibiotic. A catheter-related peritonitis is when you have peritonitis in conjunction with an exit site or tunnel infection with the same organism or one's site sterile. So this is from the ISPD guidelines. It's a logarithm regarding the management of gram-positive organisms. So you need to follow that, and you know, it gives a nice summary of what to do if you've got you know, staphylococcus. So the antibiotics for staph is 3 weeks treatment. For MRSA, they recommend teicoplanin and daptomycin. And to reduce relapse, they suggest the use of rifampicin for 5 to 7 days. Corneobacterium, they recommend treating for 3 weeks. This has a high rate of catheter removal. Streptococcus, they recommend ampicillin for 2 weeks. Enterococcus, they recommend the use of ampicillin for 3 weeks. Enterococcus is often associated with a lot more pain and has a high rate of catheter removal. So treatment of gram-negative organisms. This is a nice chart showing you the management. And then we have culture-negative peritonitis. Remember that it shouldn't be more than 15%. If it is, you need to improve the culturing methods. Now the ISPD guidelines, if you've got negative cultures on day 3, you need require a repeat effluent white cell count with a differential. So the antibiotic treatment is usually 2 weeks if the effluent clears. If the culture-negative peritonitis is resolving at day 3, then discontinue the minor glycoside therapy, but continue the gram-positive cover first generation cephalosporin or vancomycin for 2 weeks. If peritonitis is not resolving within 3 days, you need to consider unusual organisms such as Mycobacteria, Legionella, Nocardia. And if a suboptimal response after 5 days, then they removing the catheter. So for fungal peritonitis and TB, fungal peritonitis has a high rate of hospitalisation, catheter removal and transfer to hemodialysis, and a 25% mortality. This can happen with prolonged antibiotic usage. So the ISPD recommends immediate catheter removal and recommends the use of continuing antifungal drugs for 2 weeks after catheter removal. So this is your amphotericin B and flucytosine. So for Mycobacteria, which is an infrequent cause of peritonitis, patient can have prolonged symptoms despite the antibiotic therapy and relapsing peritonitis with negative cultures. So remember, you need a different culture technique for diagnosing Mycobacteria. And the treatment requires multiple drugs such as rifampicin, azithromycin, pyronizamide and ofloxacin. Now for polymicrobial peritonitis, this is where we may have multiple enteric organisms. It's maybe in association with anaerobic bacteria. The risk of death is increased and surgical evaluation should be obtained. So these patients should be treated with metronidazole in conjunction with vancomycin and aminoglycoside, or ceftazidime for a minimum of 3 weeks. So if you've got multiple enteric organisms, you need to consider possible intra-abdominal pathology. So treat with effective antibiotics for 3 weeks. Review your patient's technique or contamination, catheter infection. So if there's no clinical improvement within 48 hours, then re-evaluate. You need to send the second sample to the lab, look at the white blood cell count, the gram stain culture, look for intra-abdominal pathology, unusual organisms such as mycobacteria, fungus, tunnel infections, abdominal abscess. Daily clinical judgment is vital, so you really need to keep a close eye on what's going on. So the ISPD guidelines recommend timely catheter removal for relapsing, recurrent or repeat peritonitis. So refractory peritonitis, so that means a failure to respond to antibiotic therapy within 5 days. Refractory exit site or tunnel infection, repeat peritonitis, fungal peritonitis, mycobacterial or multiple enteric organisms. They recommend catheter removal. So some hospitals practice removal and reinsertion the same operation. This is only successful if the white cell count is less than 100. Can be done for if you've got a tunnel infection or biofilm in the catheter. It's contraindicated if you've got refractory peritonitis, Staph aureus, gram-negative Pseudomonas, Enterococcus fungus, Mycobacterium, or intra-abdominal abscess. And they recommend that you rest the peritoneum for 2 weeks after removal before you reinsert a new catheter. So just on the last slide, it's crucial to lay the foundation for interventions directed at the major causes and predisposing factors. So whenever you get an episode of peritonitis, you need to review the patient's technique, because often it's related to contamination. So some of these factors are the catheter. The guidelines recommend broad spectrum antibiotics 1 hour prior to catheter insertion. Exit site care, so they recommend the use of topical antimicrobial creams and regular inspection and cleaning of the exit site, possibly biocompatible solutions. You need to have good guidelines and protocols in place for treatment of contamination, what to do if they have dental procedures or gynae bowel procedures, so that these protocols are followed. The training is very important. Don't shorten the training. Make sure you have regular home visits. Retraining may be necessary. All of this is to prevent touch contamination. And then the PD connectology. So the twin bag or double bag systems have been shown to be superior in the prevention of peritonitis. So in summary, prevention of infection using standardised training protocols, good patient education, suitable PD systems, and adequate follow-up after the patient is discharged home. Treatment of Staph aureus nasal carriage particularly your diabetics and immunosuppressed patients. Prompt diagnosis and treatment, so you need to follow the ISPD guidelines. Early catheter removal if the patient fails to respond to the treatment at an adequate period of time, and then to routinely monitor and review your peritonitis rates and your exit site infection rates. Thank you very much.